Assalamu alaikum. My name is Dr. Iftikhar Sadiq, and I'm a consultant gynecologist. And the area of my specialty is infertility and ART, assisted reproductive technologies. So I'm going to deliver a small talk on the infertility, subfertility, the types of it, and how will we can proceed for a diagnosis and the treatment in a couple who presents with infertility. So basically, infertility has uh, two types. Classical teaching is there is primary subfertility and the secondary subfertility. Primary subfertility is considered or called when a couple never had a pregnancy ever before, and the secondary subfertility, the couple had a pregnancy irrespective of the outcome of the pregnancy, but they had a pregnancy and later on they are facing difficulties in conceiving. The standard definition for infertility is, or I must say was, which is written in the books, is that the failure to conceive after 1 year of regular unprotected intercourse. The couple is living for at least 1 year together and they have had no problem having sexual intercourse and still they're not conceiving. But this definition probably needs some change or need to be updated according to this epidemiological data. If you see this data, you see a couple after marriage, the chances of getting pregnancy in first month are only 9%, whereas chances of getting pregnancy after 6 months, uh, 80%. And after a year of living together, 85% of the couples will be pregnant. And thereafter, the small number of patients get pregnant after 2 years, 3 years. So after the 3 years, 96% of the couples they can get pregnant naturally, and there are only 4% couples are left who are involuntarily childless. In ideal situation, the couple should stay together uh, and wait for the pregnancy. But according to our society and the pressures the lady can have after the pregnant marriage, so they don't wait till that long, and they reach the clinics very early. So then this depending on this epidemiological data, so the question arises when to start the treatment. So if you recall this slide again, you see the 80% of the couples they do conceive within the 6 months of marriage. So now it is advisable if somebody is not getting pregnant within 6 months of pregnancy, they can approach a gynecologist or a consultant infertility specialist to see what is wrong with them or is there is any problem or not. So after 6 months of marriage, having uninterrupted coitus, a patient can seek a treatment. But there are certain exceptions that every couple should not wait 6 months. There are certain exceptions, and if these points are present, they should see consultant. Sorry, I beg your pardon. This should see the consultant as early as possible. So, if a lady is more than 35 years of age and there is a history of tubal or pelvic surgery, or there is a disease of pelvic disease, or there are some menstrual abnormalities like she's having amenorrhea or oligomenorrhea, means she's never had a period or she's having infrequent menstruation, or there is a history of some pelvic disorder like there's a presence of fibroid or anything else, then she should see the infertility consultant as early as possible. Likewise, in males, if there has been any testicular disorder, the male has received chemotherapy or radiotherapy, there has been any previous urogenital surgery, and usually these kind of surgeries that done when in their childhood, or there is like hernia or or like undescendants testis. There is a history of STD in males, typically gonorrhea, or there is a history of varicocele. They should not wait for 6 months, and they should seek the medical advice as early as possible. Uh, so there are there are before jumping onto we must know that there are certain factors which they are physical factors, or we can say there are certain natural factors which can reduce fertility. So any couple who is approaching you uh, after 6 months of conception, 6 months of marriage, and they're not getting pregnant, these factors should be sort, sorted, or try to find out these factors in the patient's history. As you see, I have written that the female who is 35 years of age has the reduced chances of pregnancy as compared to the younger counterparts. If a lady has never conceived, she will face difficulty in getting pregnant as compared to the ladies who has given birth to a child before. If they are very obese or they are very slim, they can also affect the chances of getting pregnancy. Smoking is linked with poor sperm motility, so it can also be contributing factor in not getting pregnant. Inappropriate quadriplegia. Most of the couples from our villages or the small cities, and the husbands are living abroad, they're working abroad, they're coming infrequently to Pakistan. The wives are here back in the villages, so their quarter frequency is very poor. And whenever they come back to their home, and probably that is not the right time to having a sexual intercourse, and the lady, most of the time, the ladies don't get pregnant when their husbands are around. So this inappropriate quarter frequency can also be a contributing factor in reducing fertility. So any illness, the prolonged illness like tuberculosis or HIV or ACV can also have bad effect on patient's fertility. And if but among all these factors, the very important factor is the age factor in female. If you see this diagram, you can see that the age of the lady and the is the chances of getting pregnancy, that is relative fertility, is very high at 20, and it's almost half by the age of 40. So it is said that the chances of fertility is reduced to 67 or 70% by the age of 35 if all the other factors are not there. By the age alone, the chances of getting pregnancy at 35 years of age are 60% less than at the age of 25 or 20. So the age of the female is also very important. So having said that, so when the couple comes to you for the treatment or the workup for the infertility, so keeping in mind these factors, when you take the history, you must seek these factors in the history. So the history should have these points, that what are the year, how many years of marriage, the quarter frequency, female age, previous pregnancies, previous surgeries, cycle abnormalities, and all that we have just discussed before. So after taking history, the next step is that we have to get answer of two very important questions. So treating a couple with infertility, primary or secondary, the job of a physician is to seek the answer of two very important questions. The question number one is, what is the cause? And the question number two is, what shall be the appropriate treatment? We, as a gynecologist or infertility consultant, never ever guarantee the pregnancy to the couple. It's not our job to guarantee them that they will get pregnant. Yes, we can guarantee them that we will find the cause, inshallah. By and once we have the right cause in our hand, we can design the right treatment for the lady. And if the both rights are together, we are confident that she will get pregnant soon. But we cannot guarantee we, the lady that she will have a baby. So being a doctor, our job as a scientist or as a doctor, not to guarantee the pregnancy. Our job is to assure her that would to find the cause, the treat, and then the appropriate treatment. So among the causes, how you see, in 80% of the cases, we are able to find the answer of the first question. We can find the cause. But in still 20% of the cases, despite our all efforts, we are never able to find the cause, and we can label them as unexplained infertility. So, first we start with when we start the workup, the first step is to uh, see the male factor. And if it male factor is fine, then we jump on to the next to find out the ovulatory dysfunction. And since the ovulation is turned out to be normal, then the third step is to find the find the tubal factor, or the tubes or the fallopian tubes are patent or not. And then, last but not least, the pelvic factor, the natural lab where the fertilization is occurring, whether it is healthy or not. So that is how we start our workup. We're starting from the simple, then up to the most complex later on. The first step is to test the male, then the ovulatory dysfunction, then tubal factor, and then the pelvic factor. So in male, the first step is to get the semen analysis. The WHO has laid down the criteria for the normal semen analysis, but before jumping on to make any remark or any opinion about the semen, we should follow these guidelines set by the WHO. The WHO says there should be two semen analyses from the two different labs, and these two semen analyses should be at least 2 months apart, and there should be at least 2 days of abstinence before going to the lab. So, if two different labs, 2 months apart, give this more or less same results, then we can make opinion about the person, that is about the semen quality of the person. So, what should be the quality of the semen, or a normal semen count? The WHO says there should be at least 15 million sperms in 1 ml of the semen. And out of these 15 million, 40% should alive, 32% mortality be there in those alive, and 4% of the sperms should have the normal anatomy or morphology. If this is the criteria from two different labs, we can label a male as a normal male. So here I conclude my first session, and the rest of the session, that is investigating a female and then the treatment, you will proceed on the next video. Thank you very much.
Hi, it's me, Dr. Iftikhar. I'm present here again, and with the second part of my presentation on fertility and subfertility. Then we have finished up to the male workup, which is the semen analysis. So, starting again from here, so here I would talked about the semen analysis. There should be 15 million count, 40% alive, and 32% mortality. So, if the semen analysis is fine, if it is not okay, we will switch towards finding the cause of the abnormal semen quality and we treat the male likewise. So if the male is found normal, the next step is to go for ovulatory dysfunction. But before that, there are certain terminology that we use when describing the semen abnormalities. Like this azoospermia, it means there is absence of sperm. If there is absence of semen, there is no semen, then we can call it aspermia. If the count is less than 15 million, we'll call it oligospermia. Oligo means small, less. And if it is less than 7 million count, then we call severe oligospermia. If there is a reduced motility, which is less than 32% the normal standard, then we'll call it asthenospermia. And then the shape is also normal, like there is some abnormalities of the tail, head, or neck of the sperm, then we label it as tetraspermia. So these are the few terminologies we use in case of male dysfunction. So once if there is abnormal semen analysis, we will try to find again, as we will try to find the cause of this semen. What is the cause? Is it azoospermia or the oligospermia or what else? So if there is a azoospermia, I mean there are no sperms, then there can be the two causes behind it. Either it is obstructive azoospermia, it means there is a occlusion of the ducts which are taking the semen out, or non-obstructive azoospermia, it means the testicular function has gone down. They are not producing sperm. So to differentiate between these two conditions, we have to go for the testing hormones. We test LH, FSH, and testosterone. LH is luteinizing hormone, FSH is follicle stimulating hormone. And if these tests are normal, it means the testicular function is normal, but there is some obstruction. So we can label it as obstructive azoospermia. And if the FSH and LH very high and the testosterone is low, it means the pituitary is working normally, but the testes are not working normally. So we call it non-obstructive azoospermia. So if there is sperms are there, but are there less than 15 million counts, we call it oligospermia or oligospermia if reduced motility is also there. So again, we get these tests done, and the results of these tests can help us to differentiate between the different conditions. Like if all hormones are low, we call it hypo situation. Then there must be some hypothalamic pituitary failure, and it is very common in Klinefelter syndrome. But in panhypopituitarism. But if there is a very high FSH LH and low testosterone, then it is we call the testicular failure. That and the Klinefelter syndrome we commonly see, and we commonly see these patients. Almost 4 to 5% of the population of infertile males they suffer from Klinefelter syndrome, which is XXY, and they present with almost azoospermia or oligospermia with high FSH and LH. But if the hormones are normal, all of them, then there's something wrong with the testicular, post-testicular cause. There can be accessory gland failure. Accessory gland means prostate or seminal vesicles. There can be hypothyroidism, then associated medical disorders, or it can absolutely be idiopathic, which constitutes the major group. There's many males who come with poor sperm count. They fall in the category of idiopathic, unexplained testicular failure. So after this, the next step is to jump onto the female workup, and then female workup again the similar situation is we need to know whether whether she's having regular ovulation or not, and for this we need to have some little understanding how the hypothalamus pituitary ovarian axis work. We call it HPG, hypothalamus pituitary gonadal axis. And to make the diagnosis of ovulatory dysfunction, we need to know about these hormones, then how do they work. So again, in females, how we go for testing that whether she is having regular ovulation or not. So first step is that we have to confirm whether she is having normal cycle length, which should be between 25 to 34. So 90% of the ladies having cycle length between 25 and 34, they have regular ovulation, but 10% of the ladies, despite having a regular cycle, they don't ovulate. So to confirm again, so the second thing is we must go for day 12 transvaginal ultrasound, which is known as TVS, and there should be a follicle which should be more than 17 mm. And there is a point to note that every lady doesn't produce egg in every menstrual cycle, so we need to confirm the presence of 17 mm follicle at least in two cycles, maybe 1 month apart or 2 months apart. And the third step is to measure the progesterone and seventh day after the ovulation, it should be above 50 nanogram. But it is very difficult to assess the seventh day because of the variation in the cycle length in different ladies, and the cycle length variation can be present in the same lady as well. So this is very difficult to find out the level of progesterone, but in clinical practice, we most of the time we rely on day 12 follicular size. So if we don't find the cycle is abnormal, or if we don't find a regular 17 mm follicle on the day 12, or the progesterone is very low, so we can label her as having some difficulty in follicular growth, or some we can call it anovulation. So to find out the cause behind this abnormal ovulation, again we have to go for the testing of the hormones, and these tests can throw a light on the problem, on the cause of the anovulation, which can be at central level like pituitary or hypothalamus, can be at ovarian level, and which can be at post ovarian level like other organs which are required to have normal ovulation. So the first thing is we order these investigations, and these are the follicle stimulating hormone, luteinizing hormone, estradiol, and AMH, which is a new armamentarium in our investigation, AMH, anti-Mullerian hormone, and we are using it very widely for the last couple of years, and it reflects almost accurately the ovarian reserve of the lady. As you know, the follicle, the lady is born with the fixed number of eggs. There is no chance that she can have a new egg once she is born. She cannot make new eggs. No drug can make new eggs. So whatever the reserve she has to make use of it for the rest of her life. And this AMH tells us whether how much this ovarian reserve is left behind, and will help us in designing the treatment of the lady. So after getting these tests, we can divide our results into four groups which are described by WHO. The group 1, 2, 3, and the last is miscellaneous. The group 1, when there is all the hormones are low, we call it hypo situation, which is a central cause. There's a problem in pituitary or in the hypothalamus. The very common conditions are Coleman syndrome and hypopituitarism. We will usually see them in our clinical practice. The second group is when the FSH/LH is low but high, and but estradiol is very low. We call it hyper situation, WHO group 2. And in this situation, either there is a premature ovarian failure or premature ovarian resistance or menopause. In these conditions are very difficult to treat because they have very low ovarian reserve, and we may not able to help them except having ovum donation. The group 3, which is very common, and this is in which there are hormones are normal or low, and this is group 10. The single condition which is found present in this group is polycystic ovarian disease, and is the leading most cause of female infertility, and it is the second most endocrine disorder after diabetes in females. The group 4 with the miscellaneous causes, which the ovary is functioning normally, but there are the organs which should work normally to have a good ovulatory function. These are thyroid and prolactin levels. So hypothyroidism or hyperprolactinemia can also cause ovulatory dysfunctions. So once you have decided that whether she's having ovulation or not, the next step is to test for tubal or pelvic factors. So for the tubal or pelvic factors, usually we test them together, and there are four ways to test them. Number one is the standard gold standard, which is known as histosalpingography, which is HSG. We put the dye and uh, the second is Hycosi is the new one, which is not there's a contrast dye is pushed into the uterus, and it can outline the uterus and the tubes, and we can see whether the tubes are patent or not. The third one is the cheap one, I mean the easy one, and we usually prefer this one as the first line of testing. If it is abnormal, then we go for HSG. This is saline infusion sonography. We just push the saline inside the uterus, and we can see under the transvaginal ultrasound whether tubes are patent or not. And the last, which is diagnostic laparoscopy, it is last but not least, because it is the ultimate test which can tell us everything about the reproductive organs of the female. If we have something, we suspect something in the pelvis, like any tumor or any mass, we resort on to the diagnostic laparoscopy. So when they should be done, the guideline is, the good practice is, they should be performed as early as semen and ovulatory dysfunctions are turned normal in primary infertility. But in secondary infertility, they should be the part of the all investigations. In primary infertility, we'll go for semen analysis first, then ovulatory dysfunction second, and then they turned out to be normal, we jump on to the pelvic factors. But in secondary infertility, we perform all these tests together because they have had normal pelvic factor before. Now they are not having pregnancy. Is it possible? It is possible that they might be having something wrong with their pelvic issues. So this is HSG. You can see the contrast dye is passed through it. This is Hycosi, and this is contrast fluid as pushed into the uterus, seen under the microscope and the laparoscopy. And the third one is SIF. And the saline has infused in the uterus, and we can see there is a small polyp hanging from the interior wall of the uterus and very well delineated due to the presence of fluid inside the uterus. So this was all about the workup of a infertile lady. And just to summarize again, when a lady comes to you, a couple comes to you, you must see a couple, and they have been married for last 6 months. They are keen to have a baby. We need to find the answer of two main questions. Number one, what is the cause behind it? And the number two, if there is any cause, how can we treat it? So, and how do we find the cause? We have to start the workup, starting from the male, semen analysis, then the ovulatory dysfunction. We go for hormones and the ultrasound to assess whether she's having normal ovulatory dysfunction. If they have turned out to be normal, then we'll go for the tubal factor, the tubes are patent or not. The gold standard is histosalpingography, and the last one is the pelvic factor, which is usually by laparoscopy. In my next video, we'll go for the ART and we'll describe about the ART. Thank you very much. Good day.